Hello, everyone. Welcome to the Osteoarthritis Action Alliance Lunch and Learn webinar for December 18th, 2019. Thank you for joining us this month. Our presenter today is Kate Queen. Dr. Queen is the medical director of the Lifestyle Medical Center, which is located in the Triangle region of North Carolina. She is a rheumatologist by training and is board certified by the American Board of Lifestyle Medicine. She has years of experience developing programs that focus on lifestyle interventions in the care of individuals with chronic diseases. She's served as a site PI for the WECAN clinical trial, which is an NIH-funded investigation assessing the impact of weight loss and physical activity on pain and function in patients with knee osteoarthritis in communities throughout the state of North Carolina. Her presentation today is titled Introduction to Lifestyle Medicine, an approach to meeting the needs of patients with osteoarthritis. Welcome, Dr. Queen.
Thank you, Kirsten. I really appreciate this opportunity to share an introduction to the field of lifestyle medicine and talk about the ways that this discipline is well suited to help us address the needs of our patients with osteoarthritis. I have no disclosures. And what I hope to accomplish in the next 20 minutes or so is to review with you the defining characteristics of lifestyle medicine and its evolution, contrasting it with other non-conventional approaches to patient care, and then focusing on how the skills of individuals who work in lifestyle medicine are well aligned with our goals for care of patients with osteoarthritis. So let's begin with the defining characteristics. Lifestyle medicine is a distinct evidence-based discipline, and it focuses on lifestyle changes for the prevention, treatment, and even at times the reversal of the lifestyle-related chronic diseases that are rampant in our world today. One of the cornerstones of lifestyle medicine is its focus on patient engagement and patient responsibility. And those who work in this field serve both as medical experts, but also have unique skills in delivering behavioral, cognitive behavioral and motivational counseling, along with coaching and leading group-based interventions. So the components of lifestyle medicine's approach to care include the following characteristics. First of all, nutrition is a cornerstone to the care we deliver, with a strong emphasis on whole foods in contrast to processed or ultra-processed foods, and predominantly, but not exclusively, plant-based choices. Physical activity, both movement throughout the day as well as structured physical activity, is one of our focuses, along with emotional wellness and engagement around stress management, the adequacy and efficiency of sleep, avoidance of risky substance use, including tobacco products, and positive psychology and the need for connectedness. Another important feature of lifestyle medicine is that it is really built on a collaborative care model, a collaborative interaction with our patients as well as our team and the patient's entire healthcare team. You might find lifestyle medicine in a variety of settings. The most common setting at the present time is integrated into primary care. So many folks who are trained and certified in lifestyle medicine are now applying it in their primary care practice. I myself am in a practice that's independent of primary care and focused just on offering lifestyle medical services. It can engage clients on an individual basis or in group encounters or in combinations. There are individuals offering it via telehealth. It aligns with the goals of many inpatient rehab programs, and traditionally has also been offered in some residential programs where patients have the opportunity to make big changes in a short period of time in their lifestyle. Threads that now make up the fabric of lifestyle medicine come from ancient times. There have, through the years, always been those who focused on the key role of nutrition and health, dating back to Hippocrates, and others who've looked to the future and have always predicted that we would do a much better job of taking care of individuals and preventing illness if we focused on self-care and nutrition. but probably the modern history of lifestyle medicine can be linked to the 1970s, when a couple of forward-thinking individuals, including Nathan Pritikin, launched programs. He put together a program that he offered at his longevity center that was a combined program of nutrition, exercise, and education. And at about the same time, John McDougall refined that to offering a whole food plant-based diet along with stress reduction and physical activity programming. Many of you will be familiar with Dr. Dean Ornish, a Harvard-trained cardiologist who in the 1980s published the Lifestyle Heart Trial, which showed that a whole food plant-based diet can result in a regression of coronary artery stenoses at 1 year and with demonstrated continued improvement at a 5-year follow-up. A contemporary to Dr. Ornish is Dr. Caldwell Estelin from the Cleveland Clinic, who took on the care of patients with critically severe coronary disease and heart failure, and again demonstrated that a whole food plant-based diet could both arrest and reverse the progression of their conditions. Hans Diehl out of the Loma Linda University community launched in the 1990s a program that's still being expanded across our country called the CHIP program, which stands for the Complete Health Improvement Program. This is an outpatient intensive lifestyle change program that has been implemented and spread. I know here in the state of North Carolina, this is available in Davidson, North Carolina, and also through the Mountain Area Health Education Center in Asheville. So it was in 1990 when WHO stepped forward and said, we want to go on record to say that yes, diet and nutrition are critical to the prevention of chronic diseases. And in the wake of that, the American College of Lifestyle Medicine was born, founded in 2004, again, growing out of the Loma Linda University community, which is a Seventh-day Adventist university. And they offered their first certification exam in 2017. So there are now 3 cohorts of folks certified to practice lifestyle medicine. Excuse me. They have published core competencies in JAMA in 2010, outlining what they feel to be the core skill set for folks who want to practice in this arena. The reality is that it wasn't until 2013 that the AMA spoke up and recognized that weight management and obesity are very critical, and obesity should be considered a chronic disease. And I have to say that in the setting of all these things I've just shared with you, today, the Centers for Medicare and Medicaid Services, which do recognize over 400 specialty codes for medical providers, do not recognize lifestyle medicine or any of the other non-traditional medical specialties. So what are some of those other types of non-conventional medicine that you may have bumped into or heard about or feel confused about? Let's begin with complementary and alternative medicine, or CAM. CAM is really a group of diverse practices and products that can be offered in medical settings and sometimes in healthcare systems. It's complementary when it's infused with conventional medicine, and alternative when used in place of conventional medicine. Historically, it has often infused ancient traditions and has not been as strong with the scientific evidence, but that's changing, and in recent years there's been a lot of new research to support the activities of folks who do complementary and alternative medicine. Integrative medicine combines CAM and conventional medicine and is a very patient-centered or personalized approach to care, and really embraces the full spectrum from physical and emotional, mental, social, and spiritual health, and includes a look at the environmental influences on health. And there are examples of healthcare institutions that we all know and recognize, including Duke University, the Cleveland Clinic, and MD Anderson, who have launched integrative medicine centers as part of their institutions. Functional medicine, on the other hand, is really focused more on physiologic and biologic function from the cellular to organ system level, and tends to look on ways one can optimize cellular metabolism, digestive function, and detoxification and control of oxidative stress. It too is growing in popularity. Some of you may be familiar with the mind-body medicine movement, which was championed by Herb Benson in Boston. This focuses on the interactions between the brain, the body, and behavior, and ways that our emotional, mental, social, spiritual wholeness impact our health directly. So those tools might include relaxation, hypnosis, visual imagery, meditation, biofeedback, and spirituality. Again, there's a growing body of science that supports the effectiveness of these tools. Preventative medicine, which is a recognized specialty of medicine, is really more of a public health and population-based intervention, although health promotion is part of preventative medicine, and it does certainly support and endorse good habits and control of chronic conditions. The historical perspective of conventional medicine, as we all know, it has really been more on seeing the patient as a passive recipient of care, and not an individual challenge to make big changes. Rather, the responsibilities have always fallen on the shoulders of the clinician to make the right diagnosis and select the right treatment, often a pharmacologic treatment and sometimes a surgical treatment. The final thing I will just mention is that obesity medicine is another specialty service available, and it is really more of a subspecialty of conventional medicine. It does focus on obesity as a chronic disease, and while it does acknowledge the role of lifestyle change, its focus primarily is on the selection of long-term pharmacologic agents for patients who cannot manage their obesity with lifestyle changes, and sometimes surgical interventions. So I can't emphasize enough how important the Affordable Care Act was to moving this movement forward. We've been going through a big paradigm shift in healthcare, but one of the key things that happened with the Affordable Care Act was that insurance companies were required to provide coverage for obesity evaluation and treatment, and that was fully phased in January of 2014. Prior to that time, anyone who was seeking care for obesity or lifestyle changes had to pay out of pocket. I will emphasize, however, for those of you that practice as I once did in a area where Medicare and Medicaid are the primary payers, Medicare coverage remains very narrow for these services. It does provide registered dietitian services in patients with the diagnosis of diabetes, but only then for a limited number of visits. So to give you just a sense of where my experience comes from, I'm working for a company that was launched in 2013, right then on the cusp of the Affordable Care Act implementation. And we're located in 4 clinics in central North Carolina in the Raleigh, Durham, Chapel Hill, and Cary area. Our team is made up of registered dietitians and advanced practice providers under the supervision of medical director. And what we do is work collaboratively with primary care providers who refer, although patients also self-refer, and we deliver the non-pharmacologic care that's necessary to successfully manage chronic conditions. So I live and work in an area where commercial insurance is the norm. We do see Medicare recipients, but that's not the majority of our patients, and we do not see Medicaid recipients because of lack of access to this kind of care. The average age of our clients is around mid-40s, predominantly female. A third or more of our clients are African American. And interestingly, 70% of our clients have completed a college education, with only 1% without a high school diploma. And what we see is 70% of our clients have BMIs of greater than 30. And of those, a third of them have BMIs greater than 40. So obesity is one of the big challenges that we face. Of this group, half of them have high blood pressure, a third have prediabetes or diabetes, almost a half have lipid disturbances. Only 4% smoke, and about a third of them screen positive for possible depression. Interestingly, half of them tell us that they're coming and seeking lifestyle guidance because they want improvement in their joint pain and body discomfort. So what you can see is that the comorbidities or the conditions that we treat are very, very similar to those that are seen in patients with osteoarthritis. We know that osteoarthritis patients have a high prevalence of obesity, hypertension, diabetes, cardiovascular disease, and depression. So the goals of our care when we're managing patients with osteoarthritis is pretty clear these days. We know that we need to reduce pain, optimize function, and in doing so, modify the process of joint damage. So we would share in our agreement that patient education and self-management skills along with goal-setting skills are really key strategies, and that the use of non-pharmacologic tools, including aerobic and strength training exercise, as well as weight loss in the range of 5 to 10% is necessary. But for those of you that are practicing and in the real world, you know that there are all sorts of barriers to actually implementing these strategies, and it makes it very frustrating to try and deliver these agreed upon goals for care. But I do think there's lots of reasons to be optimistic. And let me just refer to a couple of the key studies that have moved us forward, including the IDEA trial, which for those of you that work in this field will recognize as an 18-month randomized controlled trial that compared exercise as an intervention, diet-induced weight loss and intervention, and the combination, and showed that it was clearly necessary to, or significantly better, if we could offer both diet and exercise together in terms of pain, function, mobility, and health-related quality of life. So again, making the case for the broader lifestyle intervention. And as a springboard from the IDEA trial, the weekend clinical trial, which Kirsten referred to, is an ongoing clinical trial that's looking at whether or not we can accomplish similar results in a real-world setting in communities that are very diverse in terms of their demographics, in terms of age, income, educational status, and do this with trained interventionists, not just academic clinicians. And even more important, this clinical trial is looking at the cost effectiveness of this approach to care, with the hope that we'll have the evidence to argue that this should be a covered healthcare service going forward. So in summary, lifestyle medicine is a relatively new medical discipline focused on diet and lifestyle interventions in both the prevention, but more importantly, in the treatment of the chronic medical conditions which are so abundant in our world. Lifestyle medicine can be used to treat patients with a variety of chronic conditions, including musculoskeletal pain, diabetes, obesity, and high blood pressure, all of which are more common in individuals with osteoarthritis. And it aligns with the focus that the bone and joint community shares on self-management, weight management, exercise, in a world that this is somewhat challenging to accomplish. So please understand that lifestyle medicine providers are uniquely prepared to meet the needs of your patients with osteoarthritis, and are trained to work collaboratively not only with the patient but other members of the healthcare team, and may be available in your community. So I've just listed a couple of articles, and also you'll find my email address at the end of the presentation should you want to reach out.
Thank you, Dr. Queen. That's it's an exciting new way to look at medicine for sure. And just thinking about your last comment, one of your last comments there about reaching into communities. Of course, you reach in North Carolina. Is there a way for folks to find individuals in their communities that are trained and certified in lifestyle medicine?
So yes, I would encourage you to go to the American College of Lifestyle Medicine's website, and there they provide a listing of individuals who have been certified both in our country and some abroad. So that's the place where you'd find a formal listing of recipients of the certification.
Thank you. I also launched into that question. Just a quick reminder to anyone who is interested in asking a question, please do type your question into the chat box. And you'll also see in just a minute, we will launch a brief poll that we hope you will respond to, all of you viewers out there, so we can keep a nice quality to our Lunch and Learns. One other thing, you had mentioned a paradigm shift in healthcare early on in your presentation with regard to the Affordable Care Act. I'm curious how deeply that paradigm shift goes. Are the skills used by lifestyle medicine providers being integrated into medical school training?
So that's a great question. At the present time, there are some very exciting movements underway. There is an organization called LMED, which is focused on building a library and compendium of resources and experience for medical schools and faculty members to make this a part of standard medical school training. Probably the leading institution in our country is at the University of South Carolina in Greenville, Spartanburg. They have a 4-year, they have made changes in their entire medical school curriculum, including the basic science years, where they build in the evidence that supports lifestyle medicine. And equally as important, they have taken an approach to expecting that their trainees practice lifestyle medicine and self-care. So there is an emphasis on making sure that sleep, emotional well-being, stress, nutrition are all goals for each individual. They also have a very strong commitment to these outreaches in their community. But it's a work in progress, and I would say it is still far from the norm and certainly not part of the regular certification process for primary care training programs.
Well, it's a start.
Yep, it is.
Well, and we noted the Osteoarthritis Action Alliance had the pleasure of hosting an exhibit table at this at the American College of Lifestyle Medicine meeting this fall in Orlando, and Allison Albright from our team was manning that table, and she noted how much interest there was among the lifestyle medicine folks, the clinicians who were attending. I guess it's about 1,500 practicing clinicians who attend that meeting. Their extreme interest in educational information about osteoarthritis. As you noted, the link between OA and chronic diseases, as most of us on this webinar know, is very strong. So, the focus of lifestyle medicine on physical activity and obesity care is very well aligned with what we try to convey in osteoarthritis with our OA care tools, educational toolkit for providers, and some of those resources. So it's a great partnership, I think. We did have a question come in. How open are traditional primary care providers to having their patients work with lifestyle medicine clinicians? And are most of your practices new patients self-referred or referred from another provider?
Also great questions. So we have a group of providers who see us as a very valuable adjunct to the care that they deliver and repeatedly send patients our way. I would explain that probably about 40% of our patients are referred by primary care providers. We try to walk a very fine line and not intervene in any of the strategies that they are using. We don't get involved in any medication management and just build out those parts of the care plan that are challenging to do in a busy practice. Patients can self-refer, so the remainder of our clients come via word of mouth or from other on the internet. Some people find us on the internet as well. I will also explain that we provide services in the employee health arena as well. So we work with state government as well as a number of companies in the Raleigh-Durham Chapel Hill area to go on site, deliver exactly our same program. The only difference is that we go to them and save their employees the need to leave work, drive for an appointment, and then return. So that's another way that we access folks.
That's a great service. And I have to admit, I was a little surprised to hear you say 40% of your clients are referred from primary care. I will say that's higher than I would have expected. Do you think there's a need, or how much of a need is there to educating other types of clinical care providers about this whole avenue of lifestyle medicine?
So it's certainly one of my personal goals to help even folks in pretty narrow specialties recognize how we can help. So I definitely think the orthopedic surgical community could help take advantage of our services, even in folks who are on the path toward joint replacement, to help improve clinical outcomes at the time of surgery. And certainly with our endocrinology colleagues and even folks who are in the oncology world, lifestyle interventions are clearly important in morbidity and in some cases in long-term mortality in folks with primary malignancy. So I think there are just unlimited opportunities to partner both with primary care as well as specialists in our current healthcare settings.
Very good. Well, thank you. Physical activity, and certainly now with obesity epidemic, all of those avenues of care and looking at diet and nutrition and all of that is so beneficial across almost every other health state. So, I think it's good to have those connections.
It's true.
We'll give folks another minute to think up and type in any questions. You'll see we just launched that poll, so take a minute to respond to that. And I will give a quick shout out to our next month webinar on January 15th. That's Wednesday, January 15th. We have a slightly different format. We'll be presenting a roundtable discussion on sports and osteoarthritis for graduate students and early career researchers. Anyone is welcome to join, but that webinar, we are hoping to get that audience, and we're working with the Osteoarthritis Research Society International as a partner on that webinar. So hopefully you will be able to join on January 15th, our usual time at 12 noon. And without any further questions today, I will thank our speaker, Dr. Queen, for your time today. This very interesting talk.
You're welcome.
And thank you everyone for joining us. This concludes our presentation for today, and I wish everyone a safe and happy holiday, and we will see you in 2020.